All righty. Well, good morning, everyone. My name is Rachel Fundator. I'm a clinical associate professor at Purdue University in our Libraries and School of Information Studies. And I am going to be taking the place of Dr. Clarence Mabey, who's the director of the Institute for Information Literacy at Purdue, just for today. I'm really excited to moderate today's event with two of our speakers, which is why you are all here today. I wanted to very quickly share a little bit about the Institute for Information Literacy at Purdue, since we have some folks who might not be familiar with this. This is an institute that began about 3 years ago, and it's really an effort for us to be bringing together different kinds of researchers, not just people from libraries or information science or information studies folks, but people from different parts of academia to really examine how information challenges are playing out in the world today and affecting society, in particular communities. We really wanted to create a hub for advancing information-focused research, particularly with an emphasis on developing new information literacy models or frameworks or approaches to address some of these challenges like mis and disinformation, equitable access to information, and so forth. And so there are a range of projects that we've been working on over the years. The one in gold that you can see is our seed grants. And so two of our speakers today have received our recent round of seed grants. That being said, they are just two of the five projects that we awarded in 2024 through 2026. And these were just seed grants that were meant to support research teams who are looking to examine complex information challenges within particular contexts. So addressing certain groups of people and to help develop new information literacy models that will address or enable people really to successfully navigate and contribute to today's information environment. So up on the screen are our other projects that have been funded, and we hope at some point through our Ideal Symposium that you're engaging with today, we'll be able to feature some of these other projects as well. We have been hosting this online speaker series since July, and I want to highlight that we record these sessions. So you can go back and you can review some of the sessions. The one that's being hosted today will be recorded and will be made available on our website. It might take a couple of weeks because the person who does this work of editing and making sure things are fully transcribed, she'll be out for a couple of weeks. But rest assured, today's session will be made available online. And we will be hosting another session in January. We're about ready to confirm what that topic is, but we can't say it yet. So with that, I am just going to stop sharing my screen. Okay. I wanted to share just a little bit about today's session. We will first be hearing from Dr. Leili Seifi, and she is the PEI on her project, and Dr. Anwarul Islam will share next. We will save the questions until the end, but people are welcome to chat just to add ideas to the chat. We'll make sure to pin those questions, so as they come to you, please feel free to express them, and we'll make sure that we come back to them at the end. But if something is skipped over, please just copy that and add it back to the chat. I believe that's all that we have. So I'm just going to begin by introducing Dr. Leili Seifi. She is an associate professor in the Department of Knowledge and Information Science at the University of Birjan. She's focused on cultural heritage, community informatics, and information literacy research. Seifi has led nationally and internationally funded research grants, and she's been recognized by several ASIST awards, including the 2021 InfoShare Award. So I am thrilled to pass things over to Dr. Seifi to talk about her and her colleagues' project.
Thank you, Rachel, for the introduction. Just a minute. I'm sharing my screen. So can you see my screen?
Yes.
Hello, everyone. Good morning, good evening, good afternoon, wherever you are. First of all, thank you so much for the Institute for Information Literacy at Purdue University for the great job that they are doing. And thank you, Rachel, for inviting us to give a detail of our research project that funded by Purdue University. So I'm going just share with you all about our first phase of the project that so far we have done. So I'm our team. We are two. I'm a PI, and my co-PI is Neda Zeraatkar, Middle East and Islamic Studies librarian at Emory University. So we together have started our project, and we have so far done the first phase. Today, I'm going to share our first phase. As I said, it's based on scoping review that we have conducted. You are seeing the overview that today I'm going to share with you. First, I want to give you a brief introduction about the context that we are here living. If you know or not know, in Iran, actually women in remote access and remote area in Iran are least likely to receive adequate health care due to many health system and individual related factors such as poverty, distance, level of education, lack of information, awareness of health service, and cultural practices. And the percentage of rural pregnant women receiving prenatal care is only 20% of pregnant women in Sistan and Balochistan. I just want to focus here about Sistan and Balochistan province, that we are focusing mostly on these provinces, that they are the least province in Iran, that here women have no access to the information centers, and they get very early age marriage, let's say starting sometimes from 9 years old marriage, and no libraries at this rural area, and the distance and information transportation is very poor, and sometimes pregnant women die while going to the hospital to the cities. So this is the situational this women at this province that is as least, as I said, they are receiving the least services. And another important factor that affects prenatal care is the low level of health literacy among these pregnant women. And as I said, despite child marriage and teenage pregnancy being prevalent in Iran, especially Sistan and Balochistan and South Khorasan, there is a lack of information on the barriers that prevent rural women for accessing pregnancy-related health information. So we wanted, knowing this, and also what research already conducted on this province, saying that they need actually a kind of educational material. So that's why we wanted to improve health literacy among these rural pregnant women in Iran. And our project is focusing on access and strengthening health information literacy, that the result will be a toolkit for this community, that we want to actually train them through the different platforms. So as I said, the first phase is based on literature as a scoping review, and we investigated two questions. One was the challenges faced by a pregnant woman in Iran, and also solution to improve the health information literacy of pregnant women in Iran. So we Our method was scoping review, and we found like there are studies that already done in like from the Iranian different province in English or Persian. So we scanned both national and international databases, and finally reached to mm, 20 studies that we reviewed our actually scoping review. And the population that these studies already done was including the province, you can see Sanandaj, Tehran, Behshar, Bojnord, Mashhad, Esfahan, Bushehr, Bandar Abbas, and Baluchistan. That is mostly our focus on this research. And the result that we found that I'm sharing with you, it's first was like the type of health literacy needs that these pregnant women are actually looking for. That it's mostly focused on educational needs, access to health information, like for example, seeking health information, evaluating health information, pregnancy care, and like this kind of material, pregnant information seeking needs, and the child care information seeking needs, and health information infrastructure needs. I also want to add that in Iran, especially those vulnerable area, that most of, let's say, rural women, they have also another issue. It's about like cultural norms. And so due to cultural norms, even if they have, let's say, health centers, sometimes husbands, or let's say men at home, they don't allow them to go to the health center. So this is something that even they have, even if they have the centers, so they are not allowed to go. And this is something that you need to really prepare something ready materials and to deliver to them because of this situation. And the source that these women have used health information literacy, like, of course, media, it's like included TV and radio. Radio, it's like mostly used in, again, in those province or rural province mostly. And online information resources is like mostly internet and weblog and website. And printed information resources, those that are educated. Of course, in rural area, most of women are uneducated and very least literacy they are having. And social media, we found in, like, let's say in some province like Tehran is a capital in Iran, they are using like some Telegram or Instagram. Of course, I need to add here that in Iran, Telegram, Instagram, Facebook, YouTube, all are banned and filtered. But maybe you ask that how they are using. If we want to use these, even Zoom is banned, but we are using VPN. So this is the answer for this. And training classes, sometimes like in, let's say in cities mostly they are using. And of course, health centers mostly again in the cities, and oral communication. Oral communication is something that we found mostly between a rural area they are using, and they are focusing on that. Mostly like oral communication, including friends, family, and relative. And this is something that even the family also mostly like focus on this group, and the actually information is based on that, I would say. And the challenges these women are facing, like in accessing health literacy, it's like educational infrastructure, it's like insufficient health literacy, it's like unfavorable health information seeking behavior, and low, the low awareness is something that it's, as I said, it's like cultural norms affected these awareness, and then poor education affected these actually low literacy and lack of ability to actually access information that mostly, women, even if they have some kind of literacy, but they are not able to assess that if this information is reliable or not, because the source sometimes is not really that the sources that they are accessing is not, they don't know, it's really not reliable. And the economical and social barriers, it's like, let's say, the country is like affected by economic situation in general, but rural areas mostly like low income. And for example, as I mentioned, Sistan and Balochistan province, they have no industry in the province, and it's only like let's say their income based on agriculture, like date agriculture. So they are in very, very poor condition for their children, for their, I mean, education and everything. And social barriers, in Iran, we are like in, let's say, multicultural community, and we have Baloch, we have Turk, we have Arabs, we have Lor, so Kurd, and the ethnicity always, they are just like, let's say, kind of is isolated in the community, and so they have really very less. And as I said, it's like very mostly male dominated society in rural area, let's say. That's why that social barriers also mostly affected this access into this information. And welfare infrastructure, there is no, for example, parks, there is no sidewalks even. Let's say if somebody wants to just have a short walk in these areas, there is really nothing to just enjoy. And the health care infrastructure, as I said, lack of health centers in rural areas, especially lack of libraries, lack of doctors, and and also transportation is the main issue that rural are in very long distance. So once, if they want to get to the city or the nearest, and many women have died, by this distance and transportation. And of course, individual barriers like fear, like stress, like inactive lifestyle and aging, and language barriers that I said, like, for example, in Balochistan, they speak Balochi. So if you want to provide them material, you need to translate in Balochi. They don't know Persian. Persian is a national language in Iran. And we come up with some solution according to the literature that improvement educational infrastructure, pregnant women empowerment is very important. Of course, before that, we need really to work on the culture and these social norms that to convince these families that really you need to know. And this sometimes, even their family are not allowed to use like smartphones. Of course, in many cases they don't have capacity to buy smartphones, and those they are having, like, families are banned due to these social barriers. And so we need really awareness, and like before, pregnant woman empowerment and improvement health information awareness. As I said, this is very important that we need to work not only on women, on also like families, and the whole context, and improvement rural policies. That this is something that should be, like, for example, considering the rural approach to training programs, because it's not that easy. Even if you want to go for training, they allow you easily. So you need to really arrange, you need to talk, you need to convince. That is not easy to let's say as a, like, for example, from a different culture to enter to their community, it's not easy thing. So we need to like improvement as a rural policies and development of educational intervention. That this is the main thing that actually our project wants to do at this funded project. And if I conclude, it's like low health literacy among these women and limited information seeking behavior and low income and education affected this population. And our solution is that to teach information seeking skills and empower pregnant women to seek health information, to provide oral and visual, let's say, education in addition to written, because in most of the case they don't have enough literacy to read, to write. So it's important to consider, and also in different, in their own, let's say, local language, and present materials in brochures, in posters, and etc. And also to develop effective educational methods for women with limited reading and writing abilities, developing a platform to teach them health literacy. So this is the actually information that I wanted to share with you from our project. And of course, I want to really acknowledge and thank to Institute for Information Literacy at Porto University for funding this project. This is really great that for this rural area, I would say it's like a big thank for their work and their activities they are doing. So you can see references, and thank you so much, everyone. I'm open for questions, of course, at the end of the meeting. Thank you.
This was wonderful. Thank you so much, Leili, for sharing about the research, and we're really excited for the next phase. There's so much richness here already, and I already have some questions, and I'm sure there are questions on people's minds. But we will put a pin in it. You're welcome to add those to the chat. But just for the sake of time, we are going to move right into our next speaker and save those questions for the end. So with that, I am going to introduce Dr. Anwarul Islam. He is a professor of information science and library management at the University of Dhaka. His research interest revolves around knowledge management, service innovation, and information literacy. He's led and contributed to a number of impactful international and national projects that have received funding from ASIST, the Centenary Research Grant, and the University Grants Commission of Bangladesh. He has also received several awards from ASIST, including the James M. Krestos Leadership Award in 2022 and the Lois Lunin Award in 2023. Dr. Islam is also the PI on his project and has several other co-PIs, which he will introduce next. So with that, I will turn things over to him.
Thank you, Rachel. Let me share my screen with you first. Am I audible, Rachel?
Yes, we can see your screen.
And you can hear me perfectly, right?
Yes.
I had a sound problem here in my side. I thought it works now.
I think we can hear you pretty well.
Okay. Thank you. Good afternoon. Or should I say good night? And for the US people, for good morning, where you are from across the world joining these sessions. Thank you. And thank you for your time and passions the way you've been registered for this program and you joined. So as Rasul said, that we've been talking here with AI and health information literacy, a study exploring the perceived usefulness, readiness among women in South Asia. So this is the kind of project that we've been got fund from the Trudeau University. And for me, as Rachel said, that I'm a principal investigator. My name is Mohammed Anwarul Islam. So you can call me Islam. I'm a professor at the Department of Information Science and library management in Bangladesh. And this project is a composed of like many people from different parts of South Asia. As you see, the who we are here, my co-investigator Bhakti Gala from India. She's like a professor over there in Central University of Gujarat, and someone from Aminat Vyas from Maldives. She's also an assistant professor. Dr. Rajkumar, he is a librarian, University of Delhi, India, and Tabassum Aslam, who is also a librarian from the London School of Economics in Pakistan. So perhaps those people, you have definitely the idea of the global map, where you are, where we are, and where the other people are. So for us, the South Asia is a region of like, we call it like the SAARC nation, which is composed of like 8 countries that include Afghanistan, Nepal, Pakistan, Bhutan, Bangladesh, Pakistan, Sri Lanka, and India. And the fact is that the whole region contains 1/5 of the world populations. 100 crore, more than 100 crore people, 120, 30, or 50 crore people is situated in these regions. And as you say, that's a densely city, densely region where a lot of people are there, as well as the general literacy rate is lower compared to the other regions. So among these countries, the highest yeah, it often comes information literacy, but it's the highest literacy rate was in Maldives, that is 92%, and the lowest one is in Afghanistan, which is like 37% to 38%. And if you see the map, we are here in India, here in Bangladesh, the pink one, and there in Maldives. It shows here, but if I zoom in, the Maldives goes out from the map. It doesn't show that. As well as here, it is in Pakistan, somewhere else around that. So this is where we are. So the outline of my presentation or our team's presentation is that we did focus partly project background and objectives, country-wide activities, the activities we did conduct, I should say over the year because it's more than 1 year. It's 2 years project. We are in a mid, perhaps. I don't know the exact date. And the early finding that we have at this moment to share with us, what is our future plan, and the implication for librarianship and the kind of IL research skills it is needed. It is guided by the true things, and based on that structure, basically, I try to follow it up, fill it up. So the moment we talk about the South Asia part faces numerous challenges, including access to accurate and reliable health information, particularly for women from underrepresented or marginalized communities. That's a big region. Must huge population here. There is a common case for the women. Finally, the other thing is that the misinformation, limited literacy level, cultural barriers contribute to disparities in health outcomes and decision-making process. So this is a big challenges in places like the global south, where it is always hard to get the reliable health information. And if we flash back for the few years during the COVID time, what we noticed, the misinformation kind of health information thing spreads in these regions. It is because of we had a like lot of credible health information access and facilities here. People often rely on kind of misinformation about the health issues. And so if you see the kind of project that have been conducted under the fund of ASIS, it was all about how misinformation is spread in South Asia and make people's life dangerous situations because of low literacy rates and all those. And for the health issues, it is often treated like the women often let family members make health decisions. In a family, for a woman, if something happens, eventually she is heavily dependent on the other person in his family, like a husband, like his brother, like his father, kind of things. She cannot take the decisions independently here. Even if they have income, I mean, if they earn money, they cannot take the decision by themselves. In principle, in general, there are definitely exceptional cases in our society as well. So this can be risky because this might rely on mis and disinformation, as I say, especially if they live far from the healthcare places. We have a community health clinics. We have a hospital here, it's fine. But people feel reluctant to go to these kind of hospitals or community clinics rather than they prefer to stay at home to get some kind of uh, human-made services, human-made Medicare and kind of things. They feel comfort to stay at home and get the service. So kind of the study says, different studies say the metabolic syndrome, as well as lipids, abdominal obesity, diabetes, and high blood pressure is more significant indicator of heart disease risks in South Asian women compared to the men from the same regions. In these regions, this is the study shows how the women are vulnerable in case of disease kind of things. So the Women in Global Health chapter highlight that misinformation in South Asia is largely driven by accepting information without verification. For example, myths and taboos. It is always a big barrier in this region. You see, like country like in Pakistan, like in Bangladesh, as it's a Muslim-led countries, women often don't feel to share their health disease kind of things openly. They always feel shy and keep the information with themselves. And this kind of taboo, this kind of what should I say, myth always put their life in danger. The classical example is that in Pakistan, in breast cancer, things greatly affects the woman health in Pakistan. In 1 out of 9 women in the breast, and early detection rates are very low. It is because of the taboo. They do not want to come. They do not want to talk. Keep the disease with them until it is spread out, kind of things. So hence these situations, we feel that the project member feel that having a health information literacy things with the AI kind of things, as the AI is booming these days since 2021, the ChatGPT comes out. We thought like that this kind of project perhaps help to spread the awareness among the South Asian women in Asia, and that is why basically we've been taking this project and lead these things. As we say, the relationship between AI and people's health information is increasingly significant, and AI chatbot provides significant, more accurate answer to questions. Studies say that. So this is how we try to explain like how is AI used in healthcare applications. For example, there are a lot of features in here. For example, diagnostic imaging, treatment, personalization, drug discovery and development, virtual health assistance, predictive analytics of patients' outcome, robotics and surgery. Kind of services are directly related with the doctors. Kind of services are directly related with the users. So here, most likely, we highlighted the user's point of view for in which areas they've been taking they are taking services, they are taking kind of facilities from using AI things. So considering this, we have set a number of objectives for this project. And some of those objectives are measuring their South Asian women's health information literacy, assessing their attitudes toward AI in healthcare, identify the key factors, including their readiness, explore barriers of using AI, and develop actionable recommendations, which is definitely in our future plans to come up. And to address these objectives, shortly, we have come up with 2 research questions. One is, how do women in South Asia perceive the usefulness of AI in enhancing health information literacy? How do they feel about the AI kind of things? And what are the factors that influence to adopt AI-driven health information technologies? So to achieve these research questions, we used qualitative method, mostly focused on focus group discussions. And the focus group discussion was important in a sense, as I said, that there is a kind of taboo, there is a kind of myth, hype, female or woman doesn't want to share their things publicly. So we recruited them and leading with our rapporteur with the female or the woman participant, and we had set up everything, even during the FGD things. I was not there. I closed the door and put a tag like FGD is going on there. Females are only, women are only allowed kind of things. So this is why we choose the FGD things, because it helps to get to know the what are the phenomena, what are the taboo they have, why don't they want to talk kind of things. And the moment I was cleaning all the data sets, I was getting lot of interesting and lot of like what should I say, very significant responses, the kind of problem they face during the health issues. Because I put all the data in an Excel file. For this presentation, I was just skimming some of those data sets. And some of these findings I break it here. So due to the geographical variations, as well as due to the financial situations, and due to like the age category, we have divided the whole FGDs in three groups. The age between 18 to 30, 31 to 50, 51 is above, which is very difficult to get the respondents. We all of us from the each member countries are facing. So our initial plan is that to conduct three FGDs for each country. So with a project member from 4 countries. So in total, we aim to conduct 12 FGDs, and each FGD contains 10 members. So altogether 120 women's we are planning to recruit for this project. Until now, we did complete half of them. That is our methodology part. And the part was that, as the country is different, in Bangladesh, we speak in Bangla. Bangla is my native language. In India, there are a lot of languages, but the major one is the Hindi one. And in Pakistan, they have their own languages. As Leili said, they have the different languages. In Pakistan, they use the Urdu one. And in even Maldives, they use the Urdu one kind of things. So as the project is running, we've been writing this project, conducting all those things in English, writing our proposal in English. But to get to know the real data set, we had to translate the questions in different languages. So fortunately, the good part is that we didn't get so much pain to translate these things in the local language, because even for designing these questionnaires, different generative AI tools helps us a lot. The moment I put all the questions in English and translate into Bangla, I mean, if 70% work is done, and then the remaining 30% work I had to do to change the grammatical things and all those things. So we had to translate these languages, translate these questionnaires into local languages. And for the FGD things, it is obvious that people love to comfort to talk their local languages. So in my case, in Bangladesh, yeah, they feel happily joined. They speak Bangla, all those things. So we had recruited 2RA for my university, and there was a recording machines kind of things, soundproof room. Even the ceiling fan was not moving. If the ceiling fan moving, it gets noise. Later, it's very difficult to retrieve the data sets. So this is how basically we conducted all these FGDs from different countries. So there are some snapshots, and as I said you earlier, it is not only like in-person workshop. We in Bangladesh, I had conducted both online and offline, because conducting an online workshop or FGD things, it requires number of, requires the amount that I do not have at this moment for bearing these things. So what I had to do, I did run the first one with the in-person. This is my like university seminar library with 10 people from over there, and where is somewhere else I was standing in front of that. And this is kind of like the online one that I did conducted from Bangladesh. And this is from Pakistan, Tabassum Aslam. She did conducted one FGD through Zoom, and she's planning to conduct another one. This is from India, Bhakti Gala. She did conducted one through, she conducted two through online. And this is Amina Trias, our project member from Maldives. I'm sure like she's sitting in the sea beaches somewhere else in Maldives, because if you see the environment over there, it looks like they're in a close to the beach and kind of things. So they've been conducting all those things for the FGD things. So for the FGDs, we had a couple of interview questions, and these are the list. I'm not going to narrating all those questions here, but for some reason I just show it for it would be helpful for you to get to know. And there was screening questions. Your gender, your that we call a demographic concept, how frequently use AI tools, kind of things, your like family income in an area where you live, rural or urban or semi-urban kind of thing. This is the kind of like question that we have that we call it screening questions. So these are the major questions for our FGD things, which is started with general digital health information use and end with kind of recommendation they made. And if you see that there are 5 sections, and each sections contain 2 to 3 questions. Basically, the whole FGD is conducted with these structured questions. So let's have some earlier findings, what we got during our studies kind of thing, as I said you earlier. So the planned FGD is 12, but if you see here in Bangladesh, I did conducted one. In Pakistan, she did also conducted one. In India, we conducted two, and in Maldives, I mean, not get conducted 3 altogether. This is a kind of plan, and for each FGD contains 10 members. So this is planned FGD, member for each FGD, and completed FGD. This is a kind of FGD information things. And FGD participant S category is that 31 to 50 is like 40, and then 80 to 30 is like 30, and 50 plus is 5. And I'm afraid like to get number of respondent to contact for 50 plus categories. This is very difficult. They do not, even they don't want to listen to talk about this kind of health issues with you. So to make them understand, to recruit like student, women students, and ask her to go, they are kind of set up we are conducting. That is why the number is 5. I'm not sure now. And coming days how much we can. And the participants category is that it is like 12 was homemaker, 34 was employed, and 12 was student. In the employed category, basically I recruited the librarian, the banker, the nutritionist, someone, and and academic librarian and the public librarian. Some people I had, and the homemaker means here staying at home doing something, or they have their own business kind of things. They cook something and sell outside, staying at home kind of things. I call it like homemaker. I didn't split with the business kind of things. So the question was that are you familiar with the AI-based applications such as chatbots and virtual assistants? It's a very open and nice questions to all the participants. 25 respondents said that yes, I have, yes, they are familiar and they have used them. And remaining is like 20, 14 have said they have, yes, but they don't use them. And 14 said no, they do not familiar with that kind of things, they do not use that. They have heard the name perhaps somehow, but they don't have any idea what it is. Somehow they said, yes, I have the term ChatGPT, I have the term Gemini, but I don't know what it is. I haven't used it because I do not have my smartphone kind of things. I listen to my friends and colleagues that this is what it is. How to currently access health-related information online? How do they access to health information in online? The good part is that if you see the figure here, the histogram, the first one is the 10 respondent basically not heavily dependent on one sources. I think that is a good part. They often check with Google. If they get confused, they check with YouTube. Sometimes they check with social media. And finally, the new taboo, like the AI things keep coming. So this is a good part. At least they are not heavily dependent on single one source. It means they have some sort of understanding in their mind that perhaps single source doesn't give you the accurate information. That what it is the good part of that. And the second highest respondent came from the AI focused users like ChatGPT, AI, Dilgi Charan kind of thing. So I had asked them, our moderator was asked them kind of things, why do they use kind of ChatGPT things, AI focused user? Most likely say they want to dig out the generic of a medicine. Sometimes the doctor give the medicine name, but they do not know. So to know the which family this medicine belongs, they put the name in the ChatGPT. It helps them to get to know what kind of medicine they're taking. That kind of example they're giving more. That is for challenges faced while seeking online health information. What are the challenges they face? You see, misinformation and authenticity concerns. That's the major concern that I said you earlier before starting my slide. In South Asia, the big problem is the misinformation kind of thing. In context of religious, in context of medicine, in context of riot, in context of any sort of crisis, people spread it and suddenly it has started. The kind of feature people have, like kind of WhatsApp things, you just only need to share. That's it. This is what it is. So, seven, what examples of AI in health or daily life are you familiar with? This is, what should I say, the kind of things I was just digging out with the answer. The 16 respondents say the AI supported tools help them to get to know about the pregnancy level, to get to know positive, negative kind of things, use the, even they do not know the color they gave. What does it mean? They ask these things to the machine. If the color is like this, then what it is mean? Is it positive or negative kind of thing? This kind of response they get to that. As well as the menstrual issues, reproductive health tracking issues, kind of cycle they maintain. These are the kind of things they've been heavily used kind of surface level for getting to know about the health information. In what ways do you think I could help improve access to reliable health information? They said the good part is that 18 respondents said that it's quick. They do not need to send a call. They do not need to make a search. They do not need to read the book. They make a search to get to know what kind of thing it is. So it is instant, give them some kind of guidance. And the second one is that for simplifying and interpreting complex medical information. As I said you earlier, sometimes we do not know the complex term of a medicine or complex term of a disease kind of things. So this kind of tools always helps to dig out, make it simpler from the audience point of view so that they could understand. For that reason, they say they've been heavily reliant on these things. Are there any concern about AI providing health information? Yes. The 22 respondents said that they're afraid of the reliability and accuracy concept. And someone says that very interesting is there, and even for me, I was wondering how they are even the homemaker is getting to. She said like once I search in a Google, I get to know from where it comes because I saw the source, the newspaper, the journal article, the whatever it is. But for the strange part of AI thing that they do not know where it comes. There is no clue. They only give the query and they get the answer and they get the answer. That is why they feel reluctant for taking any sort of decision. That is why the highest number of respondents raises the serious concern about the reliability and accuracy things of AI things. How comfortable are you with using digital tools and apps that rely on AI? Here we see like 15 respondents said that they are moderate and they are conditional input. And I forget to share one thing. I'll tell you later. What kind of support of training would you make feel more confident in using such technologies? Training on safe, reliable, and authentic use of AI are the some of the areas where most of the participants they said they need to train on. They need to train on how to use these tools kind of things. Are there any cultural, religious, or social concerns that might affect the adoption of AI technologies? Yes. 20% say the digital inequality, language barrier, lack of awareness. As I said you earlier, the native language is in Bangla here, and the content of health information in the local language are very rare and not available. It is all about an English thing, so sometimes they feel it. They do not understand what it is. That is the kind of problem they face, that adoption technologies. So the language is a barrier, as well as the digital inequality. So I'm staying at Dhaka. So if I go far away from the other division, like in hill areas, like in women, like in the remote areas, but the net facilities is not good. So the kind of things they've been always suffer like the other global south countries. What do you recommend to make health information technologies more accessible to women for in your community? Said 9 respondents said it is all about awareness things. Then they said that but we need to create more awareness programs and the educational activities things in their textbook and other things. And I forget to tell you one thing. So the moment I got all the answers, for example, I had like 13 questions, and for each questions I got like 30 or 40 responses. So what I did categorize thematic analysis with all the group categories. For example, access and awareness education means it's a category of it's not a respondent number 9. It is a kind of category. So I make a big category. Under the big category, there are some responses. This is how I analyze all those things. So future effort is that, as I said you earlier, that we did conduct 3 to 5, 6, 7. In principle, we had a plan to 12 conduct 12 FGDs. So still we have to go for another 5 FGDs. That is our in the plan, and our implementation is that like roll out actionable solutions and interventions derived from the project, prepare comprehensive reports, guidelines for publications, share learning with the stakeholders, partners, and the broader community. Still, it gives a buzz to my university students and with some of my colleagues because they even don't think of that people in a reserve society like we have, they keep talking about the health information issues for a female. So it's been like buzzing. So they keep talking now. This is a kind of thing the stakeholders part. And documentation and knowledge sharing. So prepare our comprehensive reports, guides for publications, share learning with the stakeholders, partners, and broader communities. So in our future plan, identify areas for further research or exploration. As I said, this is a FGD thing, since it's very limited compared to the number of people, the number of respondents when choosing is very, very limited. So in fact, we have a future plan to do a large scale survey to get to know the must people responses. Scale the project to a larger population, religions, and applications. And implication for librarianships and information literacy research. For the librarianship, you see, if you see that the women are heavily dependent on the number of multiple sources. So this could help the library people to design the target guidance that would only rely on multiple sources like Google, YouTube, social media, AI, helping them evaluate credibility and cross-check information, not heavily dependent on one single source. That's a good part. So here the user support services can work here. The resource curation. Insights into popular platforms and information-seeking behaviors allow librarians to curate digital collections and recommend trusted sources effectively. In structural design, librarians can develop workshops or tutorials that teach critical evaluation of online health information, fostering informed decision-making among users. So implication for information literacy research. Multi-source evaluation category can be one of the areas that we can apply. Digital literacy integration and behavioral insight are some of those areas that we have a future plans. And as I said earlier, the moment we've been working with the health information literacy and AI literacy, at least one things we come to a conclusion is that for us, what we feel from the project, forget about the AI thing for a while. Think of information literacy. We we want to treat information literacy as a Trojan horse. The person who has a good information literacy skill, eventually that person will have the more power to deal with the AI things. Because if you see the AI literacy and information literacy, they have most similarities. They say the same things. Even the ChatGPT itself says at the end of the button, do not rely on ChatGPT. ChatGPT can make a mistake. Check your further information. I think which is a seed for us, the researcher, that can help to grow a tree and kind of plant. So this is where our position is. We are like working on that way. And a short write-up for our project things been published in the Information Matters in volume 4 and issue 12, where we had tried to write a bit for a while. And at this moment, this is a kind of like a short update, early findings I have for this project. And thank you so much for your patience and listening to me.
All right, thank you so much for sharing about both of your projects, Dr. Seifi and Dr. Islam. So with that, we would like folks to be able to pose some questions. So you have two options. You are welcome to add them to the chat if you prefer to do so that way. Or if you'd like to hop on the chat, please feel free to raise your hand and you can unmute. Maybe so people get a chance to sort of think about things, I'll kind of pose one question to get us started. There were so many findings from both of your projects, even though they're still in process. Can each of you share, I don't know, something that's you're most surprised or was unexpected to you? I hear a lot of sort of common things based on what you found from the scoping reviews. I'm kind of curious how that aligns with what you found. And I know, Leili, this is from your scoping review. What was most unexpected?
Can you say, Rachel?
I missed that. What was that?
Yeah, can I say that the kind of question that you had asked? I can share some things from my side.
Please.
Okay. So the moment, yeah, I'll share just a few things here. Just few things. One sec. It's close. How do I out from the yes? Can you see an Excel file? So the
No.
moment,
Oh, there we
yeah,
go.
it gets
Yes.
yeah. So the moment I was dealing with all those data sets and just a sec. Dealing with all those data sets, and I was wondering to read some of the responses again. Even someone says he cannot use the AI. He doesn't have a finger. She doesn't have a finger.
Oh.
The kind of video, the kind of problem she said, like in her responses, I don't have a finger. For some reason, she's like disabled kind of things. She often take help from his someone else.
Mm-hmm.
This kind of responses touches me, one part. And the second part is that some say that the earlier times I don't even had a courage to talk this kind of health issues, even with my brothers, even with my sisters. But the time has changed. Jamana, they say like in Bangla, Jamana has changed. I mean, the time has changed. Prithvi change হয়ে গেছে. The world has changed. They keep coming forward. So now the time has come. I'm talking these things to the indoor room with a lot of people is over there. You are recording them. Though no matter what I said to them that I'm not here, but at the end of the day, I need to cleaning the data set and everything. I'm reading every data set. So the kind of taboo they had, they said that this is amazing, Anwar. We haven't seen this kind of project even in a reserve society like we have in Bangladesh. You can contact. And finally, some of those featured news and the FGD news been updated in my university website things. I think that's a kind of, what should I say? It's a very significant thing from my side that my colleagues, my students are praising that to me. Sir, you did a very wonderful jobs kind of things. You've been up talking about the health issues of a woman, which
Mm-hmm.
is eventually forbidden. You can say that forbidden. You can say that silence. You can say that your mouth is shut up to talk about these kind of things. It is only the female doctors that are allowed to be there to talk. But it is a very common issue these days in the in the other societies as well. People keep talking their health issues, but here it is not. So in that sense, I think it's a very significant for me. Women keep coming out. They're putting their voices. We are getting to know each other. There is no harm to know that what is happening over there so that we can come and sit together to come up with a scalable solution. That's what I feel from my side. Perhaps I'm not sure how much it related with the project things, but the kind of feelings I have at this moment in my mind, just to share with you.
Thank you. What about you, Leili?
Yeah, for my side, of course, mine is we have not started interview yet, but from what I have found and so far, like knowing the context is one surprising thing is that this marriage age in rural area is starting like very early age. That is really surprising. And the other thing is the cultural norms that it's like, for example, as I said, it's a male-dominated society, and for me as a woman, it's like it's unacceptable that how, for example, in a family, one woman get pregnant, but their husband not allow them to go, for example, health center, especially when the doctors visiting doctors is a man. So this is something that they want child and they want actually many child, not one or two. They are not, but for these health things, their norms are not allowing them to take to the health centers or ask somebody to come and treat them, or even like for example to help them to improve their literacy. And even in terms of nutrition also, they are really like facing challenges and very poor, but still they are getting pregnant. And so this is something that even myself being from the context sometimes is most of the time is not acceptable to think in this way. But also like of course, like we librarians and professionals need really work, especially rural libraries, I would say. They have really, like, let's say, important role to increase this awareness, to even sometimes, these women are feeling shy to talk about their pregnancy. Can you imagine? So this is something that you really, it's like based on, and Mar also mentioned, the religious and like cultural norms, that sometimes even you feel shy to talk with your brother or even elder sister, or even sometimes really mother. Can you imagine? So this is something that again I'm focusing that librarians, especially rural librarians and public librarians, have important role to increase awareness and of course train them in our parts. This is from my side.
Thank you
Thank
so much. And we are completely out of time, and I know that people have to keep running off to their other things. So can we give one more really large applause for our two speakers? And I'm really excited to hear what continues to come out. There are some commonalities and also, contextual differences, but I think it'll be great to keep following these two topics. Thank you both so much for attending, and thank you for our attendees for being here. And you will be on a list for future events as part of this series. So thank you, everyone, and take care.